So here that goes. Okay. So Erin Sunderman is a cognitive neuroscientist and an associate professor in the Department of Psychiatry at UC San Diego. She does work in both Alzheimer's as well as cognitive impairment in people with HIV. And she, is focused at the intersection of both of those things. She's been focusing in the clinical characterization of these disorders as she's working to identify risk and protective factors and biomarkers that may allow us to distinguish these things. And so she gets the opportunity to work alongside both NeuroHIV and Alzheimer's experts. I trained with Erin Sunderman. She is a phenomenal scientist, amazing collaborator. So I just had to plug that in, Erin, because I've known you forever. So getting you here is amazing. And in addition to Erin, we get Lily Ham, who's a doctoral candidate at UC San Diego's Joint Doctoral Program in Clinical Psych, and specializing in neuropsychology. And her research is investigating adverse and protective factors underlying cognition and everyday function among people with HIV. And she's interested in modifiable factors that may serve as intervention targets during midlife to promote successful aging. So I am super excited to pass the baton to you, Erin. And I'm going to listen, and that's it. So there you go.
Thank you, Leah. That was a lovely introduction. Thank you so much. Happy to be here and be teaming up with Lily Ham, an extremely talented graduate student here at UCSD. This is work stemming from an overall grant project that myself and David Moore and Mark Bondi have been working on, essentially identifying neuropsychological and biomarker profiles associated with early stage Alzheimer's disease versus the mild cognitive deficits we commonly see in people with HIV. You want to go ahead and share, Lily?
Yes, let me go ahead and do that. Thank you again, Leah, for the lovely introduction. Let's see.
So
how does that look?
Good. Okay. I'm good with Lily and I are going to tag team this. So I'm going to do the background, and then I'll pass off to Lily, who has really been driving this study and has done all the analyzing in a fabulous job of it. Okay, so the title is The Prevalence and Clinical Significance of CSF Alzheimer's Disease Biomarkers in People with versus Without HIV. And in the way of background, thank you, Lily. So this work was very much motivated by the rapidly growing proportion of people with HIV over 50 years of age, and the new challenge that comes with aging, which is the risk of age-related neurodegenerative conditions such as Alzheimer's disease and its precursor condition, amnestic mild cognitive impairment, or AMCI. Excuse me, whether people with HIV are at higher risk for Alzheimer's disease compared to the general population is unclear. But there is evidence that people with HIV tend to develop other aging-related conditions earlier than the general population, suggesting perhaps a more accelerated aging trajectory. In addition to that, Alzheimer's disease and HIV share some pathophysiological processes, including inflammation, immune senescence, mitochondrial dysfunction, and oxidative stress, which makes it all the more important to understand how Alzheimer's disease risk may play out in people with HIV. Next slide. Okay, so amyloid beta plaques and neurofibrillary tangles that are composed of hyperphosphorylated tau aggregates, or p-tau, are the hallmark pathological features of Alzheimer's disease. And they both develop in the brain prior to clinical symptoms. This is the famous Jack curves. It's the hypothesized timeline of the Alzheimer's disease trajectory. And in this hypothesized trajectory, amyloid plaque accumulation is thought to begin 10 to 12 years before symptoms, followed by the spread of tau tangles, which more closely tracks with the onset and progression of cognitive decline. Next slide. Findings of studies examining levels of Alzheimer's biomarkers in people with HIV and their relationship to cognitive outcomes and how they compare to people without HIV have been inconsistent. This slide is focused on results with CSF biomarkers. There's, of course, work done with neuroimaging biomarkers, a lot from Bo Ansis's lab, but this is focused on CSF biomarkers since that's what we examined here. As well as plasma. So lower CSF plasma A beta levels reflect greater cerebral A beta plaque burden. And the majority of studies comparing levels of A beta, they were lower in older people with HIV and people with HIV with hand compared to people without HIV, although these levels are still far higher than seen in AD dementia patients. So not at the level we see in AD dementia, although lower than those seen without HIV. Most studies examining CSF levels of p-tau report that levels in people with HIV are not higher than those in people without HIV, regardless of age, ART status, or cognitive status. And some studies comparing CSF levels of p-tau between people with HIV with and without neurocognitive impairment found no significant difference there. Next slide. Okay, so the evidence of Alzheimer's biomarkers in people with HIV is highly mixed, but it's important to note some methodological limitations of past studies that can really affect result interpretation. So these include some large-scale mean age differences, often by 10 to 30 years, between people with HIV and a comparison group of people without HIV, particularly when that comparison group is people without HIV with AD dementia. Lack of comparative samples of people without HIV in earlier Alzheimer's disease stages, such as AMCI, which may be more relevant to our research cohorts of people with HIV who tend to skew towards the younger end of the older age spectrum. And lastly, a lack of AMCI profile characterization among people with HIV and delineation from HIV-associated neurocognitive impairment. So as such, it really remains unclear how Alzheimer's disease biomarkers compare between people with HIV and people without HIV who are better matched for age and cognitive profile. And studies that compare age match people with HIV and people without on CSF AD biomarkers focusing on earlier AD stages would help to address these limitations. Next slide. So a challenge that David Moore, Mark Bondi, and I and the team we've developed have been focused on is how to identify AMCI among people with HIV and differentiate it from the mild cognitive deficits that often occur in HIV. And this is a challenge because episodic memory deficits are the defining feature of AMCI, and they are also a common characteristic of cognitive deficits we see in people with HIV. So we did this by taking a closer look at the profile of memory impairments. And one thing that really stands out from the literature is that AMCI in Alzheimer's disease is more hippocampally based and characterized more by an amnestic profile that includes both recall and recognition deficits. And in contrast, memory deficits often seen in people with HIV are believed to be more frontal and subcortically based and typically characterized by recall impairment. but with minimal to no recognition impairment. So based on this, we adapted the Jack Bondi classification criteria for AMCI to better detect AMCI in the context of HIV-associated neurocognitive impairment. So the Jack Bondi criteria for the AMCI classification requires impairment on 2 memory tests with impairment defined by scores greater than 1 standard deviation below the demographically corrected normative mean. And our adaptation was to require at least one of those 2 impairments to be on a recognition test. So in support of this adaptation, we previously found that the Alzheimer's disease plaque burden related to AMCI classification, but not HIV-associated neurocognitive impairment in a postmortem study of people with HIV. Next slide. Okay, so on to our aim. So our primary aim was to examine how HIV serostatus, AMCI status, and their combination relate to CSF AD biomarkers. And for AD biomarkers, we looked at the classical ones, A beta 42, A beta 42 40 ratio, p-tau 181, t-tau, which is it's not specific to Alzheimer's disease and more general to axonal damage seen in neurodegenerative diseases, and the A beta 42 t-tau ratio. Our hypothesis was that we'd see main effects of HIV and AMCI status on amyloid positivity with higher rates of positivity in people with HIV versus people without HIV, and AMCI versus non-AMCI individuals. And this was based on the majority of the findings we were seeing in the literature. And hypothesis 2, also based on the literature, that we would see a main effect of AMCI status on tau positivity with higher rates of positivity in AMCI versus non-AMCI individuals. And lastly, there's an exploratory aim where we limited to just people with HIV, and we examined whether rates of Alzheimer's disease biomarker positivity are associated with HIV-related disease characteristics. And with that, I'll hand it off to Lily to get into the methods.
Thanks, Erin. Okay, so with regards to the methods, we combined actually 2 cohorts. So one was a cohort of people with HIV from the National NeuroHIV Tissue Consortium. So that was 80 individuals. This is a longitudinal multi-site study, also including organ donors. And then we also included 80 people without HIV from the Wisconsin Registry for Alzheimer's Disease Prevention, or the WRAP study. Similarly, this was multi-site longitudinal. And a good majority of these individuals reported having at least one parent with Alzheimer's disease. So we received a data set of 135 participants, requesting this from the WRAP cohort. We selected 80 participants to match our NNTC cohort based on closest age. Just kind of briefly going over how we tried to mitigate some of these methodological differences between cohorts. We looked at AD biomarker positivity for the outcome variable across these different biomarkers. So these were derived from the literature, and there were different types of assay platforms kind of used across the different biomarkers, but we used cutoffs to define AD biomarker positivity or increased risk for Alzheimer's disease. With regards to AMCI criteria, both cohorts used the brief visuospatial memory test to measure visuospatial memory. And so we were able to extract learning, delayed recall, and recognition scores from that subtest. And then for verbal memory, the Hopkins verbal learning test, or the HVLT, was used in the NNTC cohort. Similarly, a LIS learning test was used in the WRAP cohort, although they were different measures. So the Ray ABLT was used there. But for both tests, we were still able to extract learning, delayed recall, and recognition raw scores to integrate into our AMCI criteria. And so these raw scores were converted to T-scores and then demographically adjusted for age, education, and sex. And there was a race adjustment for the NNTC cohort only. Again, as Erin had mentioned, we used an adapted version of the Jack Bondi AMCI criteria. And so that was having impaired memory, which we defined as at least a standard deviation below the normative mean on 2 memory tests, with at least one of these tests being recognition. With regards to the statistical plan for our primary AIM-1 analyses, we conducted binary logistic regressions predicting odds of AD biomarker positivity. Again, being AD biomarker positive, being related to increased risk for Alzheimer's disease. Our primary predictors of interest were HIV serostatus, AMCI status, and their interaction effect. And then we force entered demographic factors of age, sex, white race, and years of education in each of the models. If there was a non-significant interaction effect, that was removed from the model just to interpret the main effects. For our second exploratory aim, we used binary logistic regressions, again predicting odds of AD biomarker positivity, but only among people with HIV. And here we were interested in HIV disease-related characteristics and their relationship to biomarkers. And so we looked at years of HIV disease, nadir CD4 count, current CD4 count, plasma viral load, and antiretroviral therapy status. Unfortunately, a lot of our analyses were limited due to substantial missingness. So we did consider different covariates that might be influential in some of the relationships we were interested here. And so that includes lifetime major depressive disorder, hypertension, and diabetes. However, due to significant missing data, it kind of precluded the inclusion of these covariates for a complete case analysis. However, we did conduct sensitivity analyses to see if these covariates looked like there was some kind of influential relationship there. And so for the models, for each HIV disease characteristic, they were conducted separately because of some of the missingness. Moving on to results. Here I just wanted to point out some of the more notable differences between the NNTC versus the RAP cohort. So just as a reminder, those in the NNTC cohort were all people with HIV, with 80 participants, and again, matched based off of closest age in the RAP cohort for all people without HIV. Despite our best efforts to match based off of closest age, you could see that there was still about a 15-year age difference between cohorts, which was notable. And then with regards to the racial breakdown, everyone in the RAP cohort was white. And as you could see with the people with HIV, there was about 63% of that cohort was white. And then among people with HIV, there was a higher proportion of men. And then with regards to some comorbidities, there were higher rates of diabetes and lifetime depression among people with HIV. Using our AMCI classification, we also saw that there was a higher proportion of people with HIV who met criteria for AMCI. And then about 44% of that cohort also met criteria for HAND or HIV-associated neurocognitive disorders, and this was based off of using Frascati criteria. Okay, and then breaking this down by our subgroups by HIV status and AMCI status, we could see that across the top, there were 39% of individuals in the dually negative group, so people without HIV and without AMCI status. And then a lot of these cohort differences were based upon cohort differences or by HIV status. And so you could see that discrepancy with age that I pointed out earlier, and then also with race. Interestingly, we see kind of a different breakdown with sex, where there's the highest proportion of men among those who are dually affected with HIV and AMCI. And we see that there's the lowest proportion of men with those without HIV and without AMCI status. And then with regards to lifetime depression, we see that those who have HIV have a higher rate of depression. Okay, so these are some graphs showing rates of AD biomarker positivity across the subgroups. These are unadjusted for covariates, but just to kind of see what these rates look like broken down by subgroups, we have some bar graphs to show here. And so the statistic here for the chi-square is just an omnibus test, and then the significant bars represent the significant pairwise comparisons that are adjusted for multiple comparisons. And so we see for AB42 that people with HIV have a higher rate of A-beta-42 positivity, so increased risk for AD compared to people without HIV. And then with regards to AB4240, we kind of see a similar relationship here, although less dramatic, but we see that people with HIV have higher rates of AB42 to 40 positivity compared to people without HIV. And then with regards to p-tau 181, there was a significant omnibus test, but after adjusting for multiple comparisons, we didn't find significant pairwise comparisons here. But you can see that there's a trend for those with AMCI having a higher rate of p-tau 181 positivity relative to those without AMCI. And then with t-tau, we see that this specific subgroup of people without HIV but with AMCI had the highest rate of t-tau relative to all other subgroups. Then lastly, we didn't see a omnibus effect for AB42 to t-tau ratio, but kind of looks like it's trending towards the dually negative group having the highest rate of A-beta-42 to t-tau positivity. So for our primary analyses here, I'm only showing the biomarker outcomes with significant main effects of HIV or AMCI status. Of note, there were only 2 people with HIV who had t-tau positivity, and so HIV serostatus was excluded as a predictor in those models with t-tau. And non-significant interaction effects were removed, so we didn't find any interactions. Therefore, we looked primarily at the main effects. And so for A-beta-42, controlling for AMCI status and demographic variables of age, sex, white race, and years of education, we saw that having HIV was associated with more than 6 times higher odds of A-beta-42 and A-beta-42-40 positivity. So pretty large odds ratios, but notably the confidence intervals are large, likely due to our restricted sample size. And then we found a significant main effect of AMCI status where controlling for HIV serostatus and demographic variables, having AMCI was related to having 3.64 times higher odds of p-tau 181 positivity. When we did sensitivity analyses, restricting the sample to some of the covariates I mentioned earlier, including major depressive disorder, hypertension, and diabetes, the findings were unchanged. And so here we just report the models without those comorbidities. This was for our exploratory aims. As mentioned earlier, due to missingness, we just conducted separate models for each of these HIV-related disease characteristics. We didn't find any significant relationships with these variables and AD biomarker outcomes. We thought this was likely due to low statistical power. So we do report the odds ratios here to kind of take a look at the effect sizes, but most of the effect sizes were small to medium. So in summary, for our first hypothesis, we found it to be partially supported where HIV status, but not AMCI status related to higher odds of amyloid positivity. For our second hypothesis, also partially supported, where AMCI classification related to higher odds of p-tau, but not t-tau and A-beta-42 t-tau positivity. Overall, we didn't really find many people with HIV who had positivity for t-tau. And then for exploratory aim, we didn't find any HIV-related disease characteristics being related to AD biomarker positivity. Even when looking across the effect sizes, we didn't really find a big signal there. Okay, so to wrap up some conclusions that we found with amyloid, we found this to be particularly noteworthy. Despite our best efforts to age match, again, there was still about an average difference of 15 years. We've older age is typically associated with greater amyloid beta pathology, and so it was quite striking to us that our cohort of people with HIV who were younger kind of had these higher rates of amyloid positivity. Some of the reasons that this could be might be due to atypical brain aging in people with HIV. That could be due to some HIV-related disease mechanisms or the prevalence of the disproportionate prevalence of comorbidities, including some metabolic and vascular risk factors that could lead to increased cerebral amyloid burden and decreased ability to clear amyloid from the brain. It's still currently unclear as to whether greater CSF A-beta positivity reflects greater risk of AD in people with HIV. So this is just kind of couching the conclusions with these limited neuropathological findings. With regards to tau, we found that p-tau might be a reliable marker of an Alzheimer's disease trajectory among people with HIV, given that, across, people with and without HIV, p-tau was related to AMCI status. Previous literature has found that p-tau is usually unrelated to cognition among people with HIV. However, these studies have typically looked at cognition globally, looking at HIV-associated neurocognitive disorders or HAND across multiple cognitive domains. However, in our study, we looked at a more specific memory deficit profile to characterize AMCI. And then lastly, the lack of relationship between AMCI and t-tau might support the fact that t-tau is more of a general marker of neuronal injury that is not so AD specific. So as mentioned before, despite our best efforts to age match, to look at AD biomarkers in this prodromal stage of the Alzheimer's disease trajectory, there was still a significant age difference. However, we find that the strength of the study is really in conducting these cross-cohort comparisons, which maximizes the use of large data sets. And with kind of using this combined cohort, we also have limitations, which include some of the methodological difficulties of trying to look across different assay platforms that are likely different in sensitivity and specificity for these biomarkers. And lastly, but importantly, there was a lot of missing data that precluded our ability to look at some potentially influential comorbidities, and there was limited racial diversity in the BRAF cohort, which was predominantly white. And as we know, Alzheimer's disease tends to be more prevalent in Black and Latinx populations, and so a lot more research needs to be conducted in this area. And with that being said, happy to open up for discussion.
Leah, do you want us to just jump in, or how should we go? I'll jump in. Great, that was a great presentation, Aaron and Lily. Such interesting data. Victor Valcour and I used to have some really spirited debates about the cognitive pattern that would best fit the amnestic profile in HIV. And one of the challenges, of course, on recognition and memory is that if people have really significant executive difficulties, they can have trouble differentiating targets from foils. And also, obviously the delayed recall is oftentimes a reflection of the saturation of the learning. So we tried to in our study that used PET to look at brain amyloid deposition. We tried to understand the amnestic profile in the context of also executive difficulties. and also look at that kind of loss function from the last learning trial to the delayed recall trial to see a true loss that would be different from just the saturation of learning. I don't know if that would net anything different in terms of results. You may have exactly the same outcomes, and you may have already explored it, but I wanted to get your thoughts on that kind of challenge with the cognitive profiling.
So Rob, that's an interesting perspective. I'm wondering how you suggest we go about it. Would it be involving executive function scores in the criteria somehow?
Yeah, that was part of our mini fun. They were really fun, but spirited debates about it's difficult to interpret, at least from my opinion, and I'm wrong on lots of things. But it's difficult to interpret a potential executive pull on the recognition memory versus the true discrimination function as a reflection of a amnestic profile. So it's just hard to see it in isolation, basically. So yeah, we tried to at least understand if someone did have a recognition impairment, did they also have profound, or that's obviously becomes its own subjective issue, but did they have significant executive dysfunction that could potentially explain the recognition difficulty? And then also, could we look at that loss function to see if there really was that amnestic loss? And if we saw the amnestic loss without major executive dysfunction, we had more confidence that it would be an amnestic profile. But that's usually what we would do kind of in a clinical setting, but it's harder to do in a research setting, particularly using, retrospective data, of course. I know you had limitations of what you could access.
Yeah, no, that's interesting. And I think we could definitely expand on our criteria to, to improve it. I just wonder, I see trickiness there too, because there's also executive function deficits associated with Alzheimer's disease.
Totally. Yeah. And the more severe, of course, the more likely. Although obviously even the diagnosis is somewhat dependent on executive dysfunction, because that's likely what explains the early IADL difficulties that actually drives the diagnosis to begin with. So I actually believe the executive dysfunction occurs earlier than what others might think in the Alzheimer's setting, but that's just my opinion again. But yeah, it's tricky, no question.
And sorry, Aaron Sunderman.
What's that, Leah?
No, I'm sorry. I got a call from my daughter, so I'm here. But it literally was as you were ending, so I'm back.
We forgive you. No worries. I hope Liza's okay.
Yeah. Anyway.
Well, thank you, Rob. Good perspective. David?
Yeah, so I really like that idea, Rob, and trying to think about how executive functioning may be intertwined in these, and we could certainly create a new AMCI that also accounts in some way for the executive functioning piece of it. But I think that this idea of leveraging recognition, whether it's executively driven or amnestically driven, is unique, because we really don't see that typically in people with HIV. So that leveraging, I think, has allowed us to see things that are more tied to what we would think is prototypically neurodegenerative amnestic type conditions. So I think we can make a AMCI plus research definition here that could investigate whether we can create even a stronger signal to noise ratio here. So
yeah, no, I totally agree. It is a significant advance over looking at just delayed recall or one metric that could certainly just be a pull from that learning function. So yeah, it's a huge step forward, no question. So good, great work.
And great talk, Aaron and Lily.
Any other questions?
Jules, I saw you had some questions about age. I don't know.
Yeah, I was just commenting, that the average age of people with HIV was 46. I don't know what the range was, but it seems awfully young to find very much of anything and to draw too many conclusions. nothing may develop for another 20 years regarding AD for people with HIV.
Yeah, no, that's definitely true. It's a younger cohort, and we'll probably see more if we were limited to older, but you know, of course, our sample size gets very low if we were to limit to, say, age 55 plus. But I'd say, you know, despite that, we see this significant threefold increase amyloid burden load in people with HIV versus people without, and the people without were older. So I think that, you know, it's notable that even with this younger group, we're seeing this increase amyloid load. We didn't see it associated with AMCI. So the question is, what's the clinical, you know, significance of this increased amyloid beta load in people with HIV? I think that's left to be determined. But you know, I think that's notable even in this younger cohort.
So, I mean, just what are we supposed to make of this? Should we be studying an older group, and why aren't we?
We do some studies that limit to older people. You know, it's often a balance between power and sample size for us. We don't quite have the numbers yet to limit to age, you know, 60, 65 and older. And I'm particularly interested in, you know, these preclinical stages, which, you know, go 20 to 30 years prior to any sort of diagnosis. But I'll let David chime in.
Yeah, I think part of the sample selection in this case was we were also looking at, you know, some of the brain neuropathology markers in this set too. So that limited who we had. And in the NNTC, I know that there are plans to start adding these markers, at least in blood and hopefully eventually in CSF. To the cohort, which that cohort on average is around 65 now. So if you take the in-life cohort. So this is something we are moving towards looking at the older group as well. But I think to Aaron's point, it's interesting that we're seeing it at such young ages. And again, with the limitation that these are all people that came to autopsy. So that may be implicating things here too. And then to leverage the RAP cohort, which usually when people do these types of studies, they compare them to people with Alzheimer's disease, and those people are much older. So we had a study where we were looking at people with Alzheimer's disease and we're comparing them to people who are 82. So even though we didn't get these groups matched on this study, we did get them closer in terms of the RAP cohort. I don't remember the average age, but it's low 60s
60.
or something. Yeah, 60. So we're closing that gap in terms of age rather than having 82-year-olds compared to, you know. But I think you're right, Jules. We need to look in the older group too.
Dorcas, I think
Yes.
Dorcas had a question.
Yeah, and this is really, really interesting, very good. And I, you know, agree with Jules about looking at older, but I was just wondering, has anything been done yet with those that are vertical transmission? I know here, we know it's about 12,000 plus in the United States, and we have those that are now in their 40s, but with them, their entire life has been HIV. Is anyone looking at them as far as cognitive studies or anything? That's all.
David, all I know is Chris Akim's Romania cohort. So Chris Akim there was a cohort in Romania of all vertically transmitted people with HIV, and they had been followed for 40 years. I think they are now at a great point to be looking at this question of, you know, age-related disorders, and I think they're, you know, a grant went in about it that was unsuccessful, unfortunately, but that's one cohort I know of. Do you know of anything else, David?
That's the primary one that I'm aware of too.
Yeah.
I
Rob
think
might know.
Yeah, I can say, so we just published a study this year. Sam Wilson is the first author. It's from Victor's R01, and that was a study that NIMH funded study that had PET confirmed risk phenotypes in terms of AD, and we didn't see any association among people with HIV compared to those without HIV in terms of PET positivity and relationship to neuropsych. And the mean age, I think, was about 70, 69 or 70. So it was truly an older cohort, but fairly similar findings in that we didn't see a very strong signal indicating greater risk, at least in terms of PET imaging results.
Thank
Jules?
Yes. Oh,
Yeah, I just wanted to ask, so my understanding is that tau is not, in people without HIV, tau presence is not necessarily predictive of Alzheimer's. Is that correct? And if that's correct, then so finding some of what you have found, I wonder how we interpret that.
Well, I'd say it's true of amyloid and tau. So, you know, the presence of the pathology in the brain, of course, puts you at higher risk of developing Alzheimer's disease later, but it's not a for sure, because there's things like cognitive reserve, of course. So there's, you know, people who have the pathology in the brain who don't develop the clinical symptoms. So when we look at biomarkers, and we see evidence of pathology in the brain, we consider it a higher risk of being on an Alzheimer's disease trajectory, but not for sure. And I'm blanking on the second part of your question. Sorry.
No, I think that was it. But so that suggests that there are so many confounders here, and lifestyle and behavior play a big role in whether someone develops Alzheimer's, right? So, you know, if you're 46 and you're sedate and you're sitting on the couch, you have a higher risk. But if then you change at 55 and start exercising, you may reduce the risk. Is that, would you say that's true?
Yeah, for sure. There's definitely a big lifestyle component to help reduce your risk. Yes, absolutely.
So this goes to my other question for you guys. So, you know, several of the guidelines, I believe HHS and HIV-MA and IAS, all recommend cognitive impairment screening for people over 50. Of course, most clinicians are not doing this. And some of the questions that come up is, well, what good is doing the testing? Because if you find something, there's nothing to do about it. But that's not really true at all, because you can recommend, you can have a frank discussion with a patient and say, listen, you may be at risk, and there are things you can do in terms of lifestyle and cognitive behavior stuff. Am I right?
Absolutely. I strongly agree with that. There are, I think, some of the strongest evidence for, you know, combating cognitive decline comes from the lifestyle intervention work.
yeah.
So yes, you're right. There are absolutely things we can do, which makes it all the more important to identify it in clinic.
Any
That go-
other? Yeah. Any other questions?
Shabani just put one in the chat, Aaron and Lily.
Okay. Let me see.
No surprise. Shabani's question is a complicated one. I'm glad I'm not responsible for answering it.
Thanks, Shabani.
Okay, I'm just going to read it out loud.
Yeah, there you go.
How does plasma p-tau217 measurements enhance understanding of this cohort status and progression? And in what ways would repeated longitudinal assessments add value? If longitudinal monitoring is beneficial, what assessment interval would you recommend based on current evidence? Sorry, not able to speak right now. No problem, Shivani. Okay, so how would p-tau measurements enhance understanding of this cohort status and progression? And then, well, I think what our results reflect is that the p-tau217 was not different by people with HIV versus our people without HIV cohorts. It related to AMCI status regardless of HIV, and it did not show a HIV serostatus effect, unlike AMCI. So I think at least our results suggest that perhaps p-tau217 may be a better marker of Alzheimer's disease risk in people with HIV compared to, say, like amyloid beta, which showed very, much higher levels in people with HIV compared to people without, but showed no relationship with our AMCI profile. And in what ways would repeated longitudinal assessments add value? I mean, of course, yes, longitudinal assessments would be extremely beneficial just to track, cognition and change in biomarkers. This is just, this cross-sectional study. It's a snapshot in time. Of course, you can have, poor sleep or something like that. That could lead to memory deficits. So if we were able to, look longitudinally and see if this is a stable amnestic profile or a declining amnestic profile, we could, better identify someone as actually, better classify as an AMCI status. And also we could support that diagnosis with looking at biomarker change over time. As for interval, perhaps, I don't know, annually. I don't know, David, do you have any suggestions based on?
I was gonna flip it on Shivani and ask her what she would do with her Alzheimer's patient. So
I like that.
But I know she can't speak. So I think, we don't know the best interval. Yeah, so I don't have a good answer there.
Yeah.
Yeah. I just had a follow-up question. Was this question, Shivani, specific to p-tau217? Because our study looked at CSF p-tau181.
Oh, you're right, Lily. I apologize. That's a good catch. So basically we didn't have this biomarker work was done a couple years ago, kind of before p-tau217 came at this and center stage. So if we were to do this all over again, Shivani, I would do p-tau217 and look at that in comparison to 181. But we don't have that data yet.
I have a question if you still have time.
Yeah.
So we're measuring tau you're measuring tau through plasma measurements, and considering these things are related to your brain function, do you think plasma measurements might be a limitation to your study, that you don't find differences between those who have HIV and not HIV? That's one question. And the other question was, do you have any other modality to look into directly in the brain, what's going on?
So I will comment that it was CSF measurements, not plasma, that we looked at. So a little bit more directly reflective of what's going on in the brain than plasma. But of course, it would be awesome if we had multimodality look at these biomarkers, and we had neuroimaging to add to that. Yeah, absolutely. That would be phenomenal. We just didn't have that data.
But Aaron, you may want to speak to the NeuroPath findings that we had using these criteria too, that we published, seeing when you use the AMCI criteria, you do see A-beta differences on NeuroPath as compared to using the hand criteria. So we are picking up something not just in life, but also in the brains of people who unfortunately passed with HIV.
Good point.
So coming back to neuroimaging, would it be, so I guess imaging would be more structural, and you could do other modalities to look into the tracts, fiber tracts. How about spectroscopy? Do you think any signal from the spectrum could be related to a chemical that you're interested in that could be related to tau?
Oh, I'm not able to answer that. I mean, I know of tau PET. I don't know of any MRS that's looking at like chemical pathways associated with tau. I don't know if anyone else does MRS work that knows about that in relation to tau.
Yeah, that I don't know.
Sorry.
Anybody else? All right. Thank you, Aaron and Lily. I think next week we have Smita Iyer from Rush University, and Caroline, I think you have the title.
Yes, it's understanding the role of CD4 T cells in HIV-associated neuroinflammation.
Awesome. So hope everybody comes back next week.
Thank you.
Bye all.
Thanks, everyone.
Thank you.